Good morning, good afternoon, and good evening, everyone. To the Honorable Evaluator, Dr. Putu Ayu Asri Damayanti M.Kes. This time, SGD B4 will make a presentation about Pneumocystis SP. Okay, operator, please go to the next slide. So this is the member of the SGD B4. Okay, next slide.
Good morning, doctor. So today we are going to explain about the first chapter is about the introduction. Then we go to the main section with second chapter, and the last about the conclusion in the chapter 3. Next.
Hello everyone. Let me introduce myself. My name is Juven Lufianto with Lasodan ID number 091. So I will talk about chapter 1, introduction of Pneumocystis SP. Pneumocystis was first identified in an animal also infected with Trypanosoma cruzi. This made Pneumocystis mistaken for morphologic form of Trypanosoma cruzi life cycle. Then, research in 1988 shows that genomic structure of Pneumocystis was more similar to fungi than protozoa. The genus Pneumocystis include variety of fungi that live and infect wide variety mammalian hosts, such as human, monkey, rabbits, rats, mice, sheep, and even aquatic mammal. Pneumocystis infection usually associated with immunocompromised people. So this is include opportunistic infection.
Good afternoon and evening, everyone. My name is Anet Malinda. My last student number is 092. I will explain about the problem formulation. The problem formulation is what is pneumocystis, what is the epidemiology of pneumocystis, what is the etiology of pneumocystis, what is the pathogenesis and pathology of pneumocystis, how to diagnosis pneumocystis, what is the treatment of pneumocystis infection, what is the prognosis for pneumocystis. And I will explain what the purpose and benefits. We are able to know about pneumocystis, able to know the epidemiology of pneumocystis, able to know the etiology of pneumocystis, able to know the prognosis for pneumocystis, able to know the pathogenesis and pathology of pneumocystis, able to know the diagnostic of pneumocystis, able to know the treatment of pneumocystis.
Hello, good morning and good afternoon, Dr. Evaluator. My name is Felix. My last 3 digit is 099. I will continue the presentation regarding the chapter 2. Next. So, regarding the history and taxonomy of Pneumocystis strophaceae. Pneumocystis strophaceae is a host-specific extracellular opportunistic fungal pathogen. Pneumocystis is one of causative fungal agent in immunocompromised patients. It has been widely known since the beginning of AIDS pandemic during the 1980s. Due to its rapidly high number of cases in HIV patients, it is also often perceived as AIDS characteristic disease. Next, about the history. The history vector of Pneumocystis strophaceae started in the right on the type of 19th century by the Carlos Cangas, which are a Brazilian doctor. He was the first to notice the cyst form of Trypanosoma cruzi in the lungs of neopics and patients. Cangas accepted this cyst form were Trypanosoma cyst. Consequently, he named this as Cystistomatum cruzi. Later on, Antonio Crani found and recognized the organism as Pneumocystis, a separate organism, in 1910. The genus and species of the organism was discovered in rats at the Pasteur Institute by Deleuze in 1920, which was later named Pneumocystis carini in the honor of Antonio Carini. Later on, Van der Meer and Berg, two Dutch researchers and scientists, identified this pneumocystis as a human pathogen in 1942. Dr. Joseph von Neck, a pathologist, found pneumocystis was the causative agent of pneumonia during the autopsy of lung section at Charles University at Prague in 1951. In 1952, Pneumocystis carini was reported to be the causative agent of intestinal pneumonia. During that period, only a few cases were reported in grown-ups, which usually almost in a malnourished state. During the onset of HIV epidemic, cases of patients with pneumocystis increased dramatically and become publicly recognized as an opportunistic infections. Initially, the term of Pneumocystis carini was alluded to the pathogen in both rats and humans. However, in 1976, Frankel found a distinction among humans and rat pneumocystis in morphologic and physiologic. In order to easily distinguish the organism, which only can be found in the humans, the term of Pneumocystis carini was changed into Pneumocystis strophaceae in the honor of French pathologist Otto Girofech. Next is about the taxonomy of pneumocystis. These are the taxonomy, start from the phylum, subphylum, class, order, and family. Regarding the species, most of the species mainly use PCR-based method, and only few species have been categorized and named according to International Code of Botanical Nomenclature rules, which are Pneumocystis strophaceae, carini, murina, wackefield, and orchidology. Next.
Hello, good morning, good afternoon, and good evening to doctor. My name is Christian, and my last 3-digit student ID number is 096. Now I want to tell you about the epidemiology of pneumocystis. The colonization may happen at higher rates in solid children than in solid grown-ups. So research has said that 30% of 175 people, especially children all over the world, is in the SIDS or sudden death identification. And then youngsters kicking the bucket of an unexpected newborn child demise syndrome likewise have a high pace of pneumocystis, and it is observed on microscopy of lung examples. That's why the transmission of this infection of pneumocystis is not known yet until now.
Morning, good afternoon, and good evening. Let me introduce myself. My name is Asri with last 3-digit student ID number 097. So I will continue with PCP in the developing world. So the World Health Association assessed that 42 million people were living with HIV toward the finish of 2002, and that 95% of these people live in non-industrial nations. Enormous bits of the population of Southeast Asia and Sub-Saharan Africa are tainted with HIV, and expected 55 million people will pass off on AIDS in Sub-Saharan Africa from 2000 through 2020. HIV is additionally expanding in zone, for example, Latin America, Eastern Europe, and Asia. In spite of expanding in the universe to supply moderate treatment to these countries, HAART is not generally accessible. So PCP, or pneumocystis, actually happens every now and again in numerous parts of the developing world. And studies from Thailand shows a prevalence of 27% to 40% among HIV-tainted patients treated at a college medical clinic facility. South America have countless PCP cases, and one Brazilian examination found that 55% of HIV-contaminated people with respiratory objection were determined to have PCP. Albeit a little examination investigation of his hospitalized Brazilian patient discovered simply 13% to have PCP. And other studies say in this local report, PCP predominates from 24% to 29%, contingent upon the population examined. Next.
Good morning, good afternoon, doctor. My name is Damayanti. My 3 last digit student number is 093. So today I'm going to explain about etiology, morphology, and life cycle. So about the pneumocystis itself, it was first found by Carlos Chagas in 1906 that it caused pneumonia. So the morphology is exists with 2 kinds of form. The first is the trophic form, which is formerly called the tropozoites, and also the cyst form, which also known as the spore case. And there are 2 types of life cycle in its life cycle form. So the first one is the asexual phase, and the second one is the sexual phase. The sexual phase is start with the trophic form, replicates by mitosis. Then the sexual phase is haploid trophic forms, conjugate and produce a zygote or sporozoites or early cyst. The zygote undergoes meiosis and subsequent mitosis to produce a haploid nuclei. Then spores exhibit different shapes. It is postulated that elongation of the spores precedes release from the spore case. It is believed that the release occurs through a rent in the cell wall. After release, the empty spore case usually collapses, but it retains some residual cytoplasm. A trophic stage where the organisms are probably multiplied by binary fission is also recognized to exist. The organism causes disease in immunosuppressed individuals.
Hello, my name is Azami Rasalfatila with student ID number 094. I will explain about pathology and pathogenesis. Pneumocystis jirovecii or PCP rarely causes disease in people with normal T lymphocytes. However, some PCP can survive latently in the alveolar septal wall in asymptomatic people and causes infection when the person has immune system deficiency. Transmission of this organism is suspected from person to person via respiratory droplet infection and direct contact with the kiss as an infection formed in humans. The transmission will go through in utero from mother to the infant. PCP will cause infection in both parts of the lung. Sometimes it also can spread to extrapulmonary location. PCP enters by inhalation, settles in the alveoli, then live in the surfactant layer on the surface epithelial alveoli tegment cell. In certain circumstances, this organism settles in the layer and undergoes reactivation when there is an immune system disorder. In this state, PCP increases in number and fills the alveoli. This organism will cause damage to type 1 alveoli cell. The damage that occurs causes decreased oxygenation, thickening of interstitium, and fibrosis. When this happens, the alveoli and bronchial will be obstructed by the mass of fungi that have already proliferated, resulting in asphyxia, which leads to respiratory failure. Next.
Hello, my name is Almanda Chandra with last 3-digit student number 086. After chapter, we learned about the pathology and pathogenesis. Pneumocystis could be diagnosed with two ways, invasive and non-invasive. The gold standard will be collecting bronchoalveolar lavage through bronchoscopy, which is invasive. In emergency times, the patients could not collect specimens in such invasive way, so using induced sputum or oral fluids could be used, but non-specific and non-targeted specimens. But now the technology has evolved through PCR. We could get rapid and non-invasive diagnosis tests for pneumocystis pneumonia. Next.
So good evening, good afternoon, and good morning, doctor. Today I'm going to explain about the treatment of pneumocystis. So the first treatment is azeotropic treatment of pneumocystis. The treatment of pneumocystis in children without immunodeficiency states is currently the administration of trimethoprim or sulfamethoxazole. The dosage is 120 milligrams 4 times a day, more often in combination with furazolidone, about 1 tablet 4 times a day, or tricopol 4 tablets per day in 1 until 2 weeks. The treatment of pneumocystis in AIDS patients must necessarily be combined with pathogenetic and symptomatic treatment, as well as with antiretroviral therapy, which is prescribed in the period of convalescence after pneumocystis pneumonia. And there's a basic mode. The basic mode to use trimethoprim or sulfamethoxazole is prescribed from the calculation of trimethoprim about 15 until 20 milligrams per kilogram per day, or from the calculation of sulfamethoxazole about 75 until 80 milligram or kilogram per day, or intravenously drip for 21 days. The daily dose is divided into 4 doses. After a 2-week admission, it is necessary to carry out a control study of peripheral blood. The development of severe disorders shows the appointment of folic acid preparation. Next.
Okay, hello, my name is Yosefina Gasutaji with class student ID number 8087. Okay, I will continue the explanation about treatment of pneumocystis. Okay, the third one is alternative treatment of pneumocystis. This treatment is by giving clindamycin for 600 milligrams every 8 hours, intravenously drip, or 300 to 450 milligrams every 6 hours, along with an initial 30 milligrams per day inside for 21 days. And the last one is pathogenetic treatment of pneumocystis. It is directed mainly to improving respiratory and cardiovascular activity. It should be intensive into the development of respiratory failure. And the appointment of glucocorticoids indicated there are prednisolone at 80 milligrams per day for 5 days, then for 40 milligrams once a day for 5 days, then 20 milligrams per day.
Okay, thank you. My name is Putu with last 3-digit student ID number is 098. So prognosis, pneumocystis pneumonia patient can be divided into 2 parts, the infected and the non-infected with HIV. The non-HIV sufferer have a worse developmental tendency when compared to patient with HIV. It is based on several factors used to compare the condition, including such as lymphopenia, adjunctive steroid use, and pneumothorax. In non-HIV patients between survivor and non-survivor, it was found that non-survivor had low lymphocyte level, lower qPCR-CT value, and higher rate pneumothorax. In fact, also obtained that non-HIV sufferer had a higher percentage of respiratory failure and mortality than patient with HIV. Patient with this disease, especially non-HIV patient, only last an average of 60 days. So it is often called as 60-day survival. Okay, for the next speaker. Next slide.
Okay, my name is Anggi Amanda Trina Devi with last 3 digits of student ID number 088. I will continue the presentation. Next. So in conclusion, pneumocystis jirovecii can cause pneumocystis, which is one of the major causes of opportunistic fungal in immunocompromised patients. Colonization of pneumocystis may happen at higher rates in children than in grown-ups. Pneumocystis jirovecii is an extracellular pathogen. The primary infection site is in the alveolar capillaries, the intraveolar septum interstitial, and epithelial cells. It can cause asphyxia and leads to respiratory failure. The gold standard in diagnosing pneumocystis is using BAL in combination test between microscopic and immunofluorescent stain. Treatment of this disease in each patient must be combined with pathogenetic and symptomatic treatment and also antiretroviral therapy. Drug that can be prescribed for patient is trimethoprim or sulfamethoxazole. Non-HIV pneumocystis pneumonia sufferers have a poor developmental tendency and have a more higher rates of death than those with HIV. That's all from me. Next.
Okay, I think that's the end of this presentation. We thank you for the attention and we are sorry for any deficiencies in this presentation. Thank you.